Okay, good morning, everyone. This is Neil Davis, pediatrician, medical director for pediatric community-based care for Intermountain, welcoming everyone to our pediatric COVID WebEx. Just as a couple reminders in terms of how the WebEx runs, please remember to mute yourself. And with questions, feel free to enter your thoughts or questions using the chat function. If you hover down near the lower part of your screen, you will see the chat box and be able to enter any questions there. Why don't we go ahead and get going? We are very fortunate to have a couple experts with us today to talk about at least the hottest topic in my world, and that is COVID-19 in schools. So Adam Hersh, who's an MD and PhD, if I remember right, Adam, with Primary Children's Hospital with the infectious disease team there. Really, really grateful you can join us, Adam. And then, as many of you know, Eddie Stenehjem with infectious disease here at Intermountain, as well as a medical director in the Office of Patient Experience. So we're very fortunate to have both of them here to think through some of the tough questions that we are facing as we encounter the families and kids and others in our community, to be honest. So welcome, Eddie. Welcome, Adam.
Thanks, Neil.
Hey, great to be here.
Let's go ahead and go to the next slide, Bridget. These are, for those who are on the WebEx here, these are some of the questions that we want to work through. Now, undoubtedly, you'll have other insights or comments or questions to enter into the chat function. But let's go ahead and start it just right from the top here. So what is the current, and this is for both of you, and probably Adam in particular with the pediatric hat on here, what is the current understanding of how COVID is impacting kids and adolescents medically? What's the 1-minute epi update for kids and COVID?
I'll take this. This is Adam. Can you just confirm that you're hearing me okay?
Absolutely, Adam. Sounds great.
Great. I look at this in 3 domains. Probability of acquiring the infection or susceptibility to infection, clinical illness once infected, and contagiousness or transmissibility. Only one of the 3 do we know a whole lot about, and that has to do with severity of illness once infected. And we know with a high degree of certainty and confidence that when children are infected, especially younger children, especially those under age 10, rarely do they become severely ill. Most children handle this infection very well, and many are asymptomatic. There's only a very small number of children who go on to develop severe disease, both in the context of active infection as well as the post-infectious syndrome, MIS-C, which is related. In terms of the other areas where there's some uncertainty, there's some possibility that children are less susceptible to infection in the first place as compared to adults. There's also some possibility that children are less contagious once infected than adults. But I want to emphasize that even if children are less susceptible to infection and are less contagious than adults, to some extent that may be an academic or biologic kind of question. They are susceptible to infection and they can transmit the infection to adults. There are policy implications, however, which is part of the purpose of today's discussion. So the less susceptible to infection children are, the less likely they are to go on to severe illness, and the less efficiently they're able to transmit the infection. Certainly does have implications for congregating in the context of something such as school. But again, just to emphasize, we know less about susceptibility to infection and less about relative contagiousness. But we know they get infected and we know they can contribute to spread.
Thanks, Adam. And let's use that to segue to number 2. And Eddie, you can comment on number 1 also if you would like. But if you want to launch into number 2 here, should my community open schools? And that's obviously not where we have the decision, but what are the important things we need to know? What do we know from other countries, or what's the evidence we have here in the U.S. related to that question?
Yeah, that's a pretty loaded question, Neil. So, the question of whether or not we should open schools should be based on your community prevalence of COVID-19. And I think that's where we should, start this discussion from. If you live in a community that has high rates of COVID-19 transmission right now, if your rates are going up, if your rates remain high and kind of uncontrolled community transmission, I think opening schools is going to be very, very risky. And so I think that should be kind of where we start the discussion from is your community ready to open schools? Should be dependent on your local epidemiology of COVID-19. That's first and foremost. We're getting more and more examples now from countries around the world in terms of what's happened when they've opened schools. And you really have to kind of dive into the details of these kind of case reports about, what was their local prevalence when they opened schools, and what measures did they put in place when they did open schools. And I think the story that's probably the most interesting, at least from my perspective, is the story of Israel. And so, Israel really controlled the virus quite well and pretty aggressively and put in some pretty strict measures. And, they were a country of 8 million people, and they got down to an average case count of about 100 cases per day. And they thought, then let's go ahead and open schools and, we have this virus under control. They did that. They opened schools. They have large class sizes. They have pretty dense classrooms. And they were in the middle of a heat wave. And so the children kept going to schools. They didn't use masks because of the heat. They shut all the windows. And now they have this huge resurgence of COVID-19, not only in the schools, but also has gone out into the communities and it's spread, throughout the large cities. And so I think that's an example that we can learn from that, yes, you can even have control in a community, but if you don't have the safety measures put into place in your school, you're going to see a resurgence, and that resurgence will affect not only the kids, but it affected many teachers in Israel and also impacted the community. There are other aspects I think that you can look at, particularly Norway and some Sweden, things like that, that have opened schools relatively safely, but have done so with pretty strict measures in the school, limiting class sizes, ensuring that masking and hand hygiene were there. So, I think we're learning a lot, but the core principle, I think, has to start with what does your local epidemiology say? And can you move to school safely with some of these safety measures in place? I'll turn it to Adam because I'm sure he's got other things to say about this as well.
I just echo everything that you said, Eddie. There's multiple facets here. There's what is the community, what's the community epi and transmission rates. There's the day-to-day behaviors of the community, because the most important and most successful strategy to reopening schools is to drop community transmission rates down outside the school so that this virus is not entering school or is entering school as rarely as possible. There's a lot, and we can talk as this goes on about the core mitigation strategies within the school, which are designed to minimize the possibility of transmission within the school environment. I saw something flash across the chat that I think this is, which has to do with I think it said something like, what is low community prevalence? And I think this is just an opportunity to bring up to this group that there have been some thresholds suggested for aspects of community transmission and community epi that could be used to guide school reopening. And those thresholds are two that have seen the most attention. Number one has to do with the day-to-day incidents, and that number that has been suggested is a number of 10 new cases per day per 100,000 population. Below 10 new cases per day per 100,000 population has been proposed as a threshold to consider reopening schools in a community. The sort of complementary and additional metric that's been proposed similarly, as a threshold to guide reopening is the test positivity rate, and using a threshold of 5%. That when the test positivity rate is below 5%, that's sort of a go time indicator for the ability to open schools. In countries that have successfully reopened schools, they've been well below those thresholds.
Perfect.
Not necessarily derived from lots and lots of evidence, but I think that they represent reasonable ranges to consider. You know, in our state overall, we're not too far off of that, especially in recent weeks. In Salt Lake County, we're getting very close to the threshold of 10 new cases per day per 100,000 population. If I read the state data correctly yesterday or the day before, it looked like we were right at least in Salt Lake County, we were right around 10 at like 11 or 12 new cases per day per 100,000. On the other hand, the test positivity rate, as most folks know, is quite a bit higher than that 5% threshold. But I think that those are at least some ballparks and some thresholds for folks to keep in mind and to keep track of when we look at weekly or daily data.
Perfect. Thank you both, and thank you for Benjamin for chiming in on the chat to sort of nail down some numbers there. Let's talk about core mitigation strategies, and we have it looked like let's see here, Rajiv Kadu was responding about one of those strategies, which is masking. But so core mitigation strategies, and what about parents requesting exclusion from mask use for various reasons? So let's go to Eddie to start into core mitigation strategies and hit that question from Dr. Kadu.
Yeah, I mean, this is, so critical to opening schools, and, masking is one of the core mitigation strategies, and it has to be present and it has to be there because there's certainly times in the school day that you are unable to socially distance. And so we'll get back to who should get an exemption, but, masking absolutely has to be there. And we know that, children aren't going to be 100% perfect at this. That's just the reality of this. Adults aren't 100% perfect at this. But we can't let that stop us from moving forward in terms of promoting masking in schools. We can set examples as both parents and physicians, and we're going to have to model this with our teachers, and we're just going to have to understand that that's going to be part of the school day. But I think, really importantly also is class size really needs to be a focus in this as well. And Utah has larger class sizes, and so what can they do to promote spreading kids out and ensuring that they are getting some of this social distancing? Ventilation in schools, incredibly important. We know that from decades of work with tuberculosis and other contagious respiratory infections, that increasing your ventilation, opening windows, modifying ventilation systems in schools is also critically important to really diffuse the infectious disease particles. Cleaning in schools certainly has to be there as well. And then clearly we're going to have access to testing and access to contact tracing. So those core mitigation principles are going to have to be there in any school plan to be able to consider safely reopening. And then the other concept that, Adam can touch on is cohorting. And so ensuring and trying to make sure that students remain in smaller groups throughout the day and aren't being constantly exposed to larger groups. And so when a person does turn positive, that contact tracing, that ability to isolate is limiting to that core cohort of smaller groups. And it's not having to be, contact tracing throughout the entire school. And schools are going to be some better, some worse at instituting these changes just based on, their environment and their ability to spread out. But those really have to be kind of part of a core plan to reopen. Adam, thoughts on that?
Really quick, before you jump in, Adam, we'll let you jump into that. There's a couple questions as you jump into mitigation strategies, just tuning in a little on the positivity rate. One from Tim Larson: is the 5% a cumulative positive rate, or daily positive rate? And then also from Eric: does the positivity rate include procedure screening? So if you can touch those and then get back to what Eddie was talking about in terms of cohorting and mitigation strategies.
Sure, those are great questions. The first one, cumulative versus daily versus weekly average, these details are actually so important, and it's just so crucial to not just glance at these numbers, but really ensure we know what the numerators and what the denominators. And I've got to say, I look at these numbers all the time and I get confused frequently. So it's not cumulative. It needs to be some measure of recency. So it needs to be a rolling daily average, and it is useful to have a roll, 7-day average, or a 2-week average, but again, not cumulative over that time period, but average per day. So if you look at, the test positivity rate, say yesterday or over the last week, it's, in the range of 9 to 10%. If you look at the cumulative test positivity rate throughout the pandemic in Utah, it's lower than that. It's like 7%, if I recall correctly. So there's a bias based on the epi curve. Again, just reiterating, the focus needs to be on what's happening recently, and you just got to be really careful when you look at the numerators and denominators to ensure that you're looking at either a daily or a 7-day or 14-day rolling average. So great question. The second question was, remind me.
It had to do with pre-procedure.
Oh yeah. So that's important. I mean, it does turn out that in large, when you're looking at a very large denominator, it doesn't influence the results all that much. But really, those ideally would be separated from, because that's a surveillance. That's almost like that's a different population. That's not really a measure of community spread. That's not among symptomatic patients. Being able to distinguish, being able to separate that group of patients or a group of people from the denominator sometimes is challenging, but that is an important potential bias that's introduced into our data. Just transferring into comments about mitigation, everything that Eddie said, again, just reiterating, starting kind of from the beginning of the day to the end of the day. One of the other core mitigation strategies that begins at the beginning of the day is daily symptom checks. This is a quick, easy, though admittedly not terribly sensitive way of detecting illness, and that is, ensuring that a child is just generally feeling well enough to go to school. It doesn't have a fever, isn't experiencing body aches, doesn't have a new cough, doesn't have GI symptoms, doesn't have body aches, etc. That's really, that's a responsibility of all of us in the community on a daily basis to ensure that children that are going to school, if they have the opportunity to attend school in person, are really feeling well on every given day. And then, of course, in the school environment, limiting visitors only to, really essentially only to the students and those that work in the school, masking everyone in the school community, some form of face covering is really essential. Physical distancing to the extent possible, limiting class sizes, cohorting, frequent hand washing, enhanced ventilation when possible, whether that's opening doors, opening windows, increasing the use of outdoor spaces for classroom time, etc.
Thank you very much. I'm going to jump to the question here about, should I send my kid to school, the shared decision-making process that all of us are having, and to segue into that for you, Eddie, and Adam. I'm just showing on the screen now, I believe. Can you guys see my screen okay? Mm-hmm. This is a handout that the team at Primary Children's, I know Eddie and Adam, you are part of this shared decision-making tool that can be useful, just so folks know on the line, to talk through, what are the risks. This document is not meant to make a decision for a parent, but to highlight some of the things, frankly, that Eddie and Adam have just talked about as they think through, okay, what's the risk for my individual kid? So, Eddie, to you, here's the question. Should I send my kid to school? And then here's all the nuances. We've got grandpa in my home with diabetes. We have a mom. I had one mom in clinic. I'm expecting another baby right now. What do I do with my 8-year-old? So that kind of thing, if you can start into that one, Eddie.
Yeah, this is an incredibly nuanced decision that each family has to make personally. This really kind of struck home in clinic. So I'm in clinic on Monday. I was in clinic seeing a 7-year-old patient who I'd seen in the hospital who had septic arthritis of his shoulder. He has rheumatoid arthritis, he's obese, and he has diabetes. And at the end of each visit within my ID practice, I counsel them on COVID-19 and preventing infection. And they said, yeah, we're really worried about that because we live with my grandchildren, and they have an 8-year-old and a 6-year-old that lives with them. And they were very concerned about their safety as their children or their grandchildren were going back to school. And so, I think this decision has to be made as a family and really take into context all of those things that are highlighted on this document that you're seeing here. So your community-based risk, what does it look like in your community? Are you below that mark? Again, relatively arbitrary, but 10 cases per 100,000 per day. Is your community wearing masks? What is the chance of that virus entering your school at a high rate? And then home-based risk, I think, really needs to be a large focus. It's the risk for individuals in the home is heightened, whether it be you have an expecting mom, immunocompromised parents, elderly grandparents. Those are potential situations where you would say, listen, I don't think it is safe for my kids to go to school because of the risk to our home environment. And there's so many things that go into this too. The economics of the family. Can the parents go to work, which is going to potentially offset some other risk, if they can't go to work and can't earn an income. And so, I think as pediatricians, family practice docs, internal medicine docs, these are decisions that and discussions you can help the families with in terms of placing risk on the individuals in the home and what that would mean to the individual and to the family. And these are, I think, discussions that as primary care docs that you're going to have to get used to having and helping families walk through this kind of risk-benefit ratio for their children.
Great. We're getting several questions just about the handout, so let me just take that super quickly. We're getting that sent out through the medical staff to everybody. It should be available to order in the print store by the end of the week or the first of next week. We would add that, I personally found this handout quite useful, that you circulate it as much as possible. And this is not meant to make a decision for parents, but to help them guide through their own shared decision-making process. So we're going to circulate this as much as we can. There'll be links on intermountain.org as well as intermountain.net. So Adam, I know you were involved in the creation of this handout. Anything you'd like to add to what Eddie said there?
The only thing that I would add, and I say this partly from my own personal experience. Eddie was talking about an anecdote of school, a family or a household that has school-age children, and if I understood it correctly, an elderly, I guess what would be grandparent, who has one of the most important comorbidities that's associated with severe illness. One consideration that I think people are beginning to talk about more and more in these contexts is masking at home to reduce household spread. And household transmission is where a lot of this is happening, or whether it's within the household or in family gatherings. And I think for a lot of us, including myself, with elderly parents, the idea that you would use face coverings in your own home or around your own family just seemed, just didn't even enter consciousness. Wasn't something that you even thought about. But I think increasingly, both recognizing how much community spread there is, this virus is throughout our communities, also acknowledging and recognizing just how effective masks can be in reducing transmission, especially when people are asymptomatic, when they're not taking themselves out of circulation. I would add that to this sort of whole family set of considerations and balancing the pros and cons and thinking about if there is, the inevitable interaction between a school-aged child who's going to be increasing their risk for acquiring this infection by re-entering in-person school. If that child lives in a home with someone who's at higher risk for a more complicated course, the mitigation approach, the sort of balance point to allow that child to perhaps go back to school, but at the same time reduce, not eliminate, but reduce the probability of household transmission to the most vulnerable person in the household. We may need to be talking to our families about using face coverings at home.
Neil, did we lose you?
There you go. I'm back. I was talking to myself apparently. All right, great. I just wanted to hit really quickly. Kathleen Obrey has a great question about, do we have a strategy to get the document out before people just coming in? And I would encourage everyone to be active. I sent the document to my local school board and I don't know, whatever we can do to get it out in circulation, I think is a good idea, to Kathleen's point. And as a team, we'll be working on that. So great question on that. I do want to I'll touch really quickly on the question that came in about exemptions for wearing masks. And this document also hits on that on the last page. And essentially, and you can touch on this, but the document's really clear. Exemptions should be rare. I had this in clinic yesterday, a mom with kids with asthma. She's like, I don't want my kid wearing a mask because his asthma worse. That's not what the data would suggest, that it actually may help him actually with some of the poor air quality, and that's not an exception that we grant. So if we can take that question, what about exceptions to masking? And then I really want to jump into sort of triaging. What about all the phone calls that we get to our pediatric clinics? Johnny has a runny nose. Do I test him for COVID? Can he go to school? Let's segue into that as well.
Adam, you want to take that?
Yeah, I was trying to avoid that. I with what you were getting at. I mean, I think legitimate exemptions should be extremely rare, and I think you bring up one of the most important considerations, which is asthma and the broader spectrum of reactive airway disease. There's really no evidence that wearing a mask, while it's uncomfortable, it may impair your quote unquote quality of life, but there's no evidence that it impairs, for instance, air exchange, oxygenation. This idea of CO2 retention, I think, is not supported by any evidence. As you point out, for children with asthma, wearing a mask may actually have value in reducing susceptibility to an exacerbation, whether it's by filtering out particulate matter, which may contribute from pollution, but not just, but also, our community will have transmission of viruses other than SARS-CoV-2, and wearing face coverings prevents not only acquisition of SARS-CoV-2 but all other respiratory viruses, and so respiratory viral infections are one of the most important causes of asthma exacerbations. So I don't view asthma as an appropriate exemption. I think in the youngest children there are considerations about compliance and fear, and potentially unintended consequences of being fidgety with a mask and all that. But what the experience that we've seen with younger children throughout the world, throughout the country, particularly in daycares and even in some communities where summer schools were open, and generally very favorable, that kids figure this out. Kids are very adaptable. They generally follow rules. They like to do things that their peers are doing. So I think exemptions are, a case-by-case set of considerations. I'm not aware of any single, for instance, diagnosis. There are some circumstances for children with special healthcare needs, where it could be evaluated kind of individually. But I am not I'm not aware of any obvious or clear-cut exemptions that are going to apply to many children.
Perfect. Thank you, Adam. And then Bridget, if I could ask you to share your screen again with the questions, that would be great. Adam, let's jump into the question about triaging. When we get called in our clinics, again, this is sort of stratifying, the risk stratifying in children. Question number 5 here. Kids get 6 to 8 URIs in a year, typically. Maybe with masking, it'll be a little less. We don't know. But when do we hold them out of school? When do we test them? When do they return?
Right.
How do we manage those phone calls in our primary care clinics?
Yeah, this is going to be a real challenge. Let's cross our fingers and hope that greater use of face coverings blunts some of this and reduces some of the acquisition of respiratory viruses in general. But I think the way I have thought through this, and I think this is something that's still in evolution, but the way I've been thinking through this has been to try to identify first and foremost, what are the clinical characteristics that are most associated with SARS-CoV-2? And it turns out that those clinical characteristics in children are not a whole lot different than in adults. So I think we can talk about this in general terms, both not only for children, but also for adults and teachers, et cetera, family members. And those symptoms include fever, shortness of breath, cough, myalgia, and this not that common but highly specific set of symptoms, loss of taste and smell. Those are the symptoms that in the view of many represent the higher risk symptoms that should really get one's attention and to start thinking about testing. Now we can get into, well, do you need one of those symptoms or 2 or more, et cetera. Now we're starting to get into some nuance that's difficult. But fever, for instance, which is relatively common, especially in younger children, fever alone is kind of, in my opinion, in a grayer area. But new fever and cough is a common and non-specific set of symptoms. But in the context of this pandemic, where this is the most commonly circulating respiratory virus, certainly right now, and it may continue that way throughout the entirety of the respiratory viral season, fever and cough, fever and shortness of breath, fever and myalgias, these are symptoms that need to raise concern for this infection and need to lead to serious consideration about testing. On the other hand, mild cough alone and certainly congestion, in my view, are so nonspecific and are so common, and actually runny nose or congestion, rhinorrhea, not so associated with SARS-CoV-2 infection in children. And so a new runny nose is not something that, in my view, ought to prompt testing. However, with all that said, if we want to think about the higher risk symptoms and then perhaps lower risk symptoms, I think that we're in a period during this school year when we are going to need to be really vigilant about keeping kids out of school really with any kind of symptom that could be associated with a respiratory virus. There's then going to be a differentiation between those who require serious consideration of testing versus those who just need to be out of school for a period of time until the symptoms seem to be resolving. I think this is something that is to be continued, but I think that's the best kind of starting point framework.
Eddie, this is such a big question. I'm curious what your thoughts are on this as well.
Yeah, we are currently in the process of developing some recommendations for the CDC service lines and affiliated providers in terms of the hierarchy of testing, in terms of what symptoms should go on to get a COVID test, and how do we ensure that we are not missing influenza and appropriately treating influenza in a timely manner. This is a pretty nuanced, field because of the evolution of SARS-CoV-2 testing. We have new multiplex panels coming on called the quad test, which would be point of care Some people won't have access to those, but we'll have access to the singleplex coronavirus test that we currently have. And then there's also flu antigen tests. And so this is an area that we're putting a lot of focus into right now, and will be over the next 3 to 4 weeks in preparation for the cold and flu season starting really in October and November. And so keep an eye out and look out for some new recommendations coming in terms of how to manage URIs in the outpatient setting as it relates to testing for both SARS-CoV-2 and influenza. And that's some work that Adam and I and others are going to be very engaged with in the next few weeks. I do think, to Adam's point, is that we're entering a new kind of a new culture about whether it be children going to school or adults going to work, about going to work or school sick, and that this is just not something that we can do in this environment. And so, if you have a congestion, a sinusitis, in the adolescence, those kids are going to need to stay at home. And whether or not they get tested or not is, I think, another discussion that we are going to be having and evolving. But, children that are sick, really should not be going to school, and same thing with adults.
So the simple version here is pretty much any of those symptoms, no school. Now, which of those symptoms lead to testing is what you're sorting out. Is that, Adam, Eddie, is that a fair summary there?
That is.
Yep, exactly.
Okay. I want to jump down to the question on guidance from the state. I believe that we recently got some guidance from the state. I want to make sure we cover that, and then hopefully we can hit some of the other questions. And by the way, I love the comments coming through the chat. If we don't get to your particular comment, we do collect these and try and get a response back to folks. So really, really good stuff here. But let's jump to what do we know from the guidance from the state, and what do we need to know as providers in that area?
Yeah, I can start on this. The state health department released a very comprehensive and extremely helpful document last week. I think it was almost a week ago, which in my view is a terrific starting point for thinking about kind of the day-to-day operation of school, and specifically thinking about all the scenarios that are inevitable in regards to testing and positives in a school environment. I think it's a starting point. I think it represents the consensus of, I wasn't directly involved with the preparation of it, but I think it represents the consensus of the evidence that we have. I think it's also likely that this is some of the guidance, and some of the kind of operating principles may evolve, may change as more and more stakeholders weigh in, and as we learn more about the epidemiology of this virus in school environments. But some of the key take-home points that I think all healthcare providers, and frankly all community members, need to understand, at least from my perspective, are the following. First of all, the state seems to have used the language. The state has used the language of essential workers and classifying students as essential workers, and sort of from that operational definition, there are policies that relate to potential exposure in a classroom. If a member of a classroom environment tests positive, students in that classroom in general are considered to be close contacts of that student, regardless of what's going on in the classroom in terms of mitigation strategies, in terms of mask wearing and proximity. The assumption is that a classmate of a student who tested positive is considered a close contact. The implications of that are that students are categorized subsequently in what the state is referring to as modified quarantine for school. And what that means is that when not in school, the student should be in quarantine at home, limiting their contact with people outside of the home for a 14-day period, and certainly on a heightened symptom watch for the possibility of any symptoms that might suggest with SARS-CoV-2. Because of the essential, quote unquote, essential worker status, students are allowed to return to school if they and their caregiver feel that that's in their best interest, acknowledging that there's a possibility that they could have been exposed to the virus, or that other students could, in theory, be asymptomatically infected. The operationally, how families would choose to proceed in that environment, I think, remains to be seen. But at the moment, that is one of the most important sort of operational principles. The state guidance also has provided some guide points for school closures. The recommendations as they currently stand are that if there are 3 individuals that test positive in a classroom environment, then that classroom cohort or that classroom needs to switch to remote learning for essentially an indefinite period, at least 14 days. And then similarly, if there are 15 students or school community members who test positive within a 14-day period, that the whole school would need to switch to a remote learning design for an indefinite period, at least 14 days. Whether or not those thresholds are going to be, whether or not lower thresholds would be used to decide to switch a classroom to remote learning, or to an entire school to remote learning, I think remains to be seen. But those are at least initial thresholds to guide school operations.
So let me mention a couple things as we're getting close to time, and then Eddie, I'm going to want to hear your thoughts on that topic as well. We are going to end this meeting promptly at 8 o'clock. Having said that, this WebEx will continue. The Utah chapter of the AAP will continue on a chapter chat to continue discussing this until 8:30. But for those who are on the call, 8 o'clock is when we will end this, and then segue to Elisa Stoddard and Jennifer Brinton with the Utah chapter of the AAP. So just wanted to mention that. Now, Eddie, Adam has touched on a few things here. What about the note, the requirement for like a note to return to school? I believe the state document touched on that, but I already see the writing on the wall for our clinics. How is that going to play out? How do we interface with families in that regard?
Yeah, I think this is going to be really interesting, because I think we're already starting to see some discrepancies between school districts in terms of what is required and what is not. And it does not look at this point, from what we're seeing, is that there's going to be a universal policy for this across all school districts, and whether or not you need a note from a physician to safely return to school. And so I think, as you know, pediatrics or pediatricians' offices and family medicine offices, we're going to have to be flexible in terms of managing this and having some policies for this. You know, for those people that have SARS-CoV-2 and have been infected, we strongly encourage people not to retest in order to prove that they are no longer contagious. We know that people shed this virus for long periods of time, and if we're undergoing retesting to get people back to school, people are going to be staying home much longer than they really need to. And so, you know, really focusing on those that are positive, that are known COVID-19, that are at home in isolation, that we, you know, continue to use the CDC definition that it's been 10 days, their symptoms are improving, and they've been afebrile for at least 24 hours without the aid of antipyretics. If they meet that, then yes, they can go back to school. We do not want to be doing re-swabs of these children to ensure that they're negative, because that's just going to prolong symptoms, or prolong time at home and away from school. I think the challenge is going to be, what about these kids that have URIs, sinusitis, otitis, things like that, that don't get tested? And in those cases, it's, you know, going back to our principles of, are they improved, to be able to get them back to school. And so I think we're going to have to be flexible in terms of what different school districts are going to require. We should continue to follow the CDC guidance for those that are SARS-CoV-2 positive, and be able to set up these types of practices within our clinics to do this efficiently.
That's great. Let's wrap this up. We are at 8 o'clock. I love the chat. We've got Andy Pavia and Emily Thrill chiming in. It looks like Emily and Adam are doing a Facebook Live. I think I saw that next Wednesday, so that's great. So this is going to be a conversation that will and should continue on. We will do all we can to get the documents we have circulated. We will get to the questions that are asked and send them out to everybody. Thanks, Eddie, for the very little bit on the face shields. Appreciate that. But thank you, everyone, for the great conversation, and encourage everyone to keep the conversation going with your patients, with your local school districts, with your community.